So in this randomized phase 2 trial, I should say first, we compared escalation of treatment to standard care management after clinicians have decided what the standard care will be before randomization. We found no difference in outcome recurrence-free survival between the two groups of patients, with a 2-year recurrence-free survival of 52% for the escalation group and 61% for standard care group. There are, however, some imbalances in the baseline characteristics between the two groups, with a slightly higher rate of higher-risk disease and end-2 disease and tumor deposit in the escalation arm compared to the standard care arm. Then we look at the specific subset analysis by clinical risk, but equally did not see a difference in outcome within the clinical low risk or high risk group. We found what was very interesting is that the level of ctDNA, what we call molecular burden, is highly prognostic, where you can see progressive worsening of recurrence-free survival by increasing level of ctDNA. So I decided to look at whether high or low ctDNA level could, the outcome in these patients, whether there's any difference in FOLFOXIRI or doublet chemotherapy, but we did not see a difference. So overall, as post hoc analysis comparing the triplet and doublet chemotherapy, we saw no difference. And the clearance rate are also very similar, 60% clearance with FOLFOXIRI and 62% in doublet. However, that said, there are some imbalance by protocol design. There are more high-risk patients in the FOLFOXIRI treated patients. So maybe that the fact that we didn't see a difference in outcome between the triplet versus doublet was because they're more high-risk patient. We did separately look at clinical risk disease and the outcome within the subgroup of patients. Obviously, numbers are very small, and we're definitely not powered to detect a difference. We did not see a separation in the curve. I think, this is a signal-seeking study. It is not a definitive trial. So, but the reason we did a signal-seeking study is so that we can see whether there's anything, any benefit or relevance that is worth us investigating it further. So with the results of the study currently, it would appear that intensifying cytotoxic chemotherapy may not be providing benefits to ctDNA-positive patients. Obviously, we'll await results from a couple of other huge larger randomized phase 3 trial internationally to see whether there's any benefit. But I do think that this is an opportunity for us to explore novel therapy in the adjuvant setting in addition to chemotherapy in this high-risk subgroup of patients, rather than keep escalating cytotoxic chemotherapy, which on its own does come with increasing toxicity. Yeah, I think there's a lot of new targets now in colorectal cancer. We saw BRAF mutation being, BRAF inhibitor and encorafenib cetuximab combined with chemotherapy being so much more effective than the BRAF inhibition alone in the first-line setting for BRAF mutant cancer. We now have new treatment for HER2-targeted treatment, and then there's the suite of KRAS targeting agents coming through. So potentially, if these agents are active in the metastatic setting, we could bring them forward to the adjuvant setting to explore them. So obviously, this is hypothesis generating only. We need to see clinical trial data to support its use. Well, what we found was ctDNA clearance was highly prognostic. It really reflects the adjuvant treatment efficacy. Although clearance is not currently accepted as a surrogate marker or surrogate endpoint for definitive randomized phase 3 trial, we will need much more lots more data from a randomized phase 3 study in order for it to be regulatory accepted as a surrogate endpoint. But I think in earlier phase 1 or phase 2 signal-seeking trial, you can certainly use ctDNA clearance as a early no-go signal, which would hopefully speed up drug development. And similarly, I think having such a strong biomarker to enrich for patients to explore new therapy, I think is a huge advantage to reduce the inefficiency of adjuvant drug development.